my pleasure today to introduce Deval Gor, who is a PhD candidate in our program here. Deval completed bachelor's in pharmacy and a master's in pharmacy from 2 different universities in India before becoming an assistant professor at Nirma University and at the Charitar University of Science and Technology. She then came here for a PhD, and while doing her PhD here, has been an intern at AppB here in Chicago. She's also been awarded a couple of awards, the Chancellor Student Service Award and the Van Doren Scholars Award in the past. So today she's going to be talking about the cost effectiveness of a novel personalized medicine service, which is a project that she's been working on with Dr. Nitescu. So really look forward to hearing this presentation, and thank you.
And Dr. Walton.
And Dr. Walton.
And several of our graduate students, people care also has to be acknowledged for his contributions.
Yeah.
Sure, Deval will do that.
Yeah.
All right.
Yeah, question.
Yes. Would you please set the record straight once and for all? For us, pronounce your first name.
Deval.
Deval. I didn't want to. Oh, Deval. Thank you very, very much.
Yeah, thank you. Okay. Okay, so the topic of my presentation is about the personalized medicine program or the service and it's based on UIC's own data. And the outline of my presentation includes a brief background on the personalized medicine service, like how it's been adopted at UIH, what are the different features of our program, and like what kind of outcomes we are assessing to evaluate the evaluate the outcomes. And then I'll be describing the particular study that I'm addressing here is the economic outcomes of adopting this service. So in general, we know that in traditional pharmacotherapy approach, if we make a decision based on a group or based on an indication that we give same drug, same dose to all patients, we may have a limitation in this approach that in certain cases we see that all patients receive good response. In certain cases, the patients may or may not have any response because of lack of efficacy, or in certain population we see that there is an increased toxicity. Now, there are various factors that can affect the drug response. One of them is the drug-related factors, like the concomitant drug therapies, other drugs being given with our indication drug. And in certain cases, there are pharmacokinetic or pharmacodynamic drug interaction, and that can affect the drug efficacy or toxicity. In other situations, there are also patient-related factors such as age, their liver or renal functions. So we also have to consider all these drug and patient-related factors. Now, even considering all these factors, we are still taking decisions in terms of a group or a group of patients. Apart from this patient-related factors, there is one other important factor, that's the genetic, that can still affect the drug response in certain situations. So basically, personalized medicine is a kind of service where you incorporate this individual patient-related factors, that's a genetic variation at the individual level. And you also consider this apart from other factors in decision making. So that's the basic rationale for using the genetic information or implementing a personalized medication program. So talking about the importance of it is, it's by FDA. FDA has published guidelines for incorporation of genetic variation results or genotyping results into use of certain medications, and it includes more than 100 medications where this information could be used for proper decision making, proper dosing, and it's available for various therapeutic areas such as cancer, chemotherapies, antidepressants, antithrombotic agents, and there are several guidelines that can be used for deciding the correct dose, such as the guideline from Clinical Pharmacogenetic Implementation Consortium or CPIC guidelines. Now basically the importance of this genotyping is based on the clinical utility of it. So you have to have better outcomes when you incorporated the genotyping results, and you should generally see the improvement in clinical and healthcare utilization outcomes. Now one of the way to implement this results of genotype test is to have a consult service where you receive the genotype test results and you have a consult service that would provide the dosing recommendations. And based on this premise, the UIH personalized medication program was implemented, and then these are the unique features of UIH program, where there are several phases of adoption of genotyping testing. We are currently in the phase 1, where we are focusing on antithrombotics, particularly warfarin and clopidogrel. And there are other possible phases which will focus on opiates, chemotherapy, or antidepressants. So the scope of this program is for high alert medications, the medications that are relatively widely used, such as warfarin, and also the medications which are likely to have narrow therapeutic index, or the genetic variation could increase or decrease the efficacy and toxicity. So it's a multidisciplinary approach, and pharmacy is a leader in implementation, assessment of outcomes, and checking overall program feasibility and operationalization of this program. Apart from pharmacy, there is also involvement from other teams, including from medicine school, bioinformatics for the clinical decision making support, and there is an integration of clinical workflow, including the student members also. And this program is not only about implementation of the program, but also assessing the outcomes and dissemination of these outcomes internally and externally. And it's been focused on assessing the clinical outcomes, the operational outcomes, and also the economic outcome that I'll be talking about. So this genotyping is carried out by an FDA approved genotyping test, that's by e-sensor system by Genmark, and generally the results are available within 6 hours. The genotyping testing for warfarin here is carried out for VCOR C1, CYP450 to C9, and 4F2 variants, and then various alleles for those variation. And as you know that warfarin is prescribed widely. There are like 2 million prescriptions every year for warfarin, but warfarin also known for causing therapy-related complications such as bleeding and clotting or thrombotic-related complications, and it's been said that it's one of the most common drug to result in those kind of complications in USA. Now this is the workflow, like how this whole service works. So first there is whenever there is a prescription of warfarin is entered into EHR system, there is an alert created. Now this alert is goes to the molecular pathology lab for ordering the genotyping testing, and also to the prescriber that the genotype testing is available for this kind of patients. And it's after checking the eligibility that the warfarin use is newly initiated, and then so after checking that it's a new warfarin initiation indication, then the patient's blood would be withdrawn, and then the sample would be given to molecular pathology lab for the genotyping testing. Now alongside that, since the results are not available just when you give the sample, the first dose of warfarin would be still given as per the clinical or the usual care practice. Now before the second dose is given to the patient, there will be an available results from genotypic testing results. So along with the PMP pharmacist who would be working with other team members and they will be providing a consult service based on genotyping testing results and other patient-related factors, and they would recommend a dose. So that dose would be incorporated and would be sent via an alert to the prescriber, and then the dosing recommendation would be made. So this was a basic idea like how this program works, and so far we have assessed the clinical outcomes, and this particular study is all about the economic outcomes. So the basic objective of this study was to compare this pharmacogenetic service versus the usual care, and it's from the healthcare provider perspective. So the target population here is the patients who newly started on warfarin, and they might have indication of VTE or atrial fibrillation. The compare strategies are clear. The one is the PGX cohort, or where there is the first dosing based on clinical algorithm and the subsequent doses based on pharmacy consult service and the genotyping testing results. Now the usual care cohort is a historical control cohort where the genotyping testing results weren't available because there was no genotyping test carried out, and the dosing recommendation were based on the usual practice. Now we carried out a model-based approach to assess economic outcomes and calculate the incremental cost effectiveness ratio. So now our model was based on two parts. The first part is for 90 days of follow-up, and that 90 days of follow-up is based on our own UIH data. So the effectiveness of this implementation of this program and effectiveness in terms of reducing the complication is based on UIH's own cohort for both treatment alternatives, PGX and UC. After 90 days, all the patients who survives basically just goes into one of the possible Markov states, and then those patients are followed up to 5 years. So we have 90 days treatment cycles, and then patient can transition from one state to the other stage, and that is described here. So this is basically our decision model, where patients with this indications would initiate either PGX service or the usual care, and then they may or may not have the therapy-related readmissions, which could be either hemorrhagic or thrombotic-related events. We also incorporated the possibility of single or multiple events, because in our data we had seen that some of the patients had multiple events. And after the event, if the patient survives, then they go into one of the possible Markov state that I'll describe later. And that's based on their initial indication, whether they were AF patients or the VTE patients. So these are the Markov states for patients with atrial fibrillation. So the ones in blue, or this one death, those are the possible Markov states, and these are the transition states. So these patients can either have a myocardial infarction or ischemic stroke. They can have intracranial or extracranial hemorrhage, and then they can go to other post-event stage. So these are the acute events that can happen, and if the patient suffers from MI, then they will go into a Markov state called post-MI. And in all possible Markov state, patients could die, and that's based on the probability is based on the literature. In case of VTE, the possible transition and Markov states are here. Again, intracranial, extracranial hemorrhage, recurrent VTE in terms of DVT and PE, and then all patients could die at any point of time. Now the model inputs, as I mentioned, the initial 90 days is based on the UIH cohort data, where the effectiveness is term of a hazard ratio for hospitalization, and the other probability or the risk of events in Markov states, like from having a well-managed atrial fibrillation to having an MI, those are based on the published literature. We carried out extensive literature review to incorporate this these variables from the studies that are good quality and it's most relevant to our situation. For the cost, we use hospital data for estimating the cost of providing the genotyping service, and for the cost of acute events such as MI or stroke were based on the literature review. The utility was also based on the literature review. And now we get, yeah.
Deval, you said that the perspective is the healthcare provider perspective.
Uh-huh.
Can you clarify what constitutes that perspective? Like, to me, that's a clinician's perspective.
Mm-hmm. So
Talking
it's
about the hospital?
yeah, it's more like a hospital perspective.
Okay.
Yeah. So when I mentioned that the cost used from published literature, we are using the cost from HCUPNet, and we are using the actual cost and not the charges. Yes, it's not like a charged charges that would be payable for a payer. It's rather the actual cost to the hospital or a healthcare system.
Okay, thank you.
And we also did several type of sensitivity analysis. One way was carried out by changing the base case input by 25%. We also carried out the alternative scenario analysis. So in that case, so initially in the base case, the type of hemorrhagic event, whether it was ECH, ICH, the thrombotic event, whether it was MI or stroke, that was based on actual UIH cohort data. And depending on that, they would either go to one of this possible state. Now in alternative scenario analysis, we also checked if given that they have bleeding complication, whether it will be ECH or ICH, or whether given that they have a thrombotic event, what kind of thrombotic event it would be. So those in the alternative scenario was based on the published literature rather than our own data. Then we also carried out the probabilistic sensitivity analysis, where from the one-way sensitivity analysis, all the variables that changed the ICER for up to $500 per quali, we included all those variables. We assigned the distribution to those variables, and then we carried out the Monte Carlo simulations. And we also checked the impact of time period that we use on the ICER values. So these are the model inputs for the first 90 days based on UIH cohort data. So the hazard ratio was about was 0.5. Sorry. Yeah, 0.5 for the admissions in the PGX cohort compared to the usual care cohort. And these are the other variables that we used and based on the cohort data. For the genotyping, sorry, go ahead.
When you had people who had multiple events, were they, if it was thrombotic events, were all the multiple events thrombotic events? Or someone had a bleeding event, all of the bleeding?
Yes,
the events?
yes, yes.
I just wanted to make sure of that, but the way the model was structured.
Yeah, and the cost of our service was $290 for the base case, where the genotype testing cost $250, and the pharmacist consulting service would be costing $40 per patient. And these are the various inputs for the Markov states, like the probability of particular type of events and whether those events could be fatal or not. These are the model inputs for the cost parameters and the utility. And coming to the results for the base case analysis, we found that our ICER was $210 per quali. So if we consider a traditional threshold of $50,000 per quali, it was pretty much cost-effective option at the 5-year. And even if you vary the follow-up period from year 1 to year 5, we can see that even at year 1, it was about $4,700.
Deval, could you go back to that slide? The way the costs and qualities are there, it's showing that UC dominates the PGX branch. You shouldn't have an ICER in that scenario. Are these numbers flipped for the cost?
The cost is more, but the quality schemes are more.
Oh, I'm sorry, PGX is more expensive than higher. I'm sorry. I was
So it is more expensive and more
Yeah.
qualities.
Okay, you're right. Sorry.
I know the difference are not too much because at the 5-year time of period, cost kind of decreases and it becomes almost similar. When we say at year one or just 90 days, obviously there is somewhat higher cost for the PGX, but then it's paid off when you have a longer follow-up and when you consider also the qualities gained. So we also, just to look at the impact of initial cost of PGX service versus the usual care cohort and the incremental cost at just 90 days. So considering only 90 days of follow-up. So we obviously know that there is obviously $290 is a additional cost that we pay when it's a PGX service versus usual care. But then there are also readmissions that were higher in usual care cohort. So just looking at the cost, we see that at our cost, there was increase in about $40 per patient at 90 days. But then it breaks even when the cost of intervention is about $250. So basically, look, the conclusion here is that it depends like what cost you pay for the genotype testing and also the consult service. And it may eventually become the cost becomes similar or even less depending on the cost of genotyping testing. And this is a tornado diagram that shows a one-way sensitivity analysis. And we see that the important factors here again are the hazard ratio, the rates of admission in the usual care cohort, the cost of genotyping testing and the service. And also there are several variables. But the impact was higher for these variables, the effectiveness and the cost of the service. So included all these variables for the Monte Carlo simulations. Now this is a sensitivity analysis based on the alternative scenario. Even with the alternative scenario like changing the probability of type of bleeding or thrombotic event, there wasn't much difference in the ICER values. And when we change the cost of the service up to $500, we see that at year one there's a higher ICER value, but eventually it decreases with the longer follow-up period. Now this is a scatter plot for Monte Carlo simulations. 10,000 Monte Carlo simulations were carried out by assigning distribution to the input variables. And then we see that with the traditional thresholds of willingness to pay, like most of the ICER values falls below it. And this is the cost effectiveness acceptability curve. When we look at just 1 year of follow-up data at the threshold of willingness to pay of $50,000 QALY, we see that 70% of the ICERs would be acceptable for this willingness to pay threshold. And obviously when we increase the follow-up, there's more payoff. And at the 5 years, this value of acceptability is 91%. So basically we see that with our base case values and sensitivity analysis that this service was cost effective. And for the discussion, I'll just mention that this is one of a kind of service that's been implemented at UIC, and it provides a platform or a model for other institutions or academic centers that want to adopt this kind of service. And we not only implement the service, but we also consider the disseminations of the outcomes. And we have the demonstrated results with respect to operational feasibility. That has been a published paper by Dr. Nutescu, which assesses how this service can be implemented and whether it is feasible or not. And we also have previously shown improved clinical outcomes with respect to the proxies for warfarin effectiveness or toxicity in terms of time in therapeutic range, use of low molecular weight heparin in case of reducing extreme INRs, which is desirable, and also decreasing the therapy-related hospitalization or readmissions at 30 and 90 days in form of bleeding or clot-related complications. And with this particular study, we also assess the cost effectiveness of the results. Strength includes that we collected data from real-world setting. It's a comprehensive implementation of program, including and focusing on the importance of pharmacy consultation service. And we also, there were analysis of right variants based on the populations, and that also improves outcome. The limitation is a very general limitation that can happen with any model-based approach, that there are some assumptions, there are some variables that you take from the literature. But then again, carrying out sensitivity analysis can help us to see the uncertainty around the base case values and see like how it impacts cost effectiveness analysis. And just that the data was obtained from one hospital only. Now with this, I'd also like to mention the funding sources with for Dr. Nutescu. She is funded by NIH, UIC, CCTS, and CRC. And this whole program is also being funded by the Vice President, Office of the Vice President for Health Affairs. And I would like to thank all the investigators who are involved in one or the other phases of this implementation of this program, carrying out the analysis or providing inputs and suggestions. And for this project specifically, I worked with KIBM, and I worked with Dr. Nutescu and Dr. Waltons as the mentors. And also there are other involvement in different phases, and that involves PharmD students and also our own graduate student from the department. Okay, these are the references, and thank you.